Okay, I think we should get started. I see in the chat box that maybe a slightly delay in the login because of some kind of loop that you may encounter, but let's get started. So today is the last of our initial series of seminars from the Data and Analysis Centers, so the sixth, and it's on health financing. And the point of these first series of six seminars was really to look at annual reviews from different perspectives and see what the Data and Analysis Centers could offer. So I think we're keen to hear from you all what other topics we will tackle in the second round when we go deeper into certain areas. Of course, we've also started as Countdown a series of how-to video tutorials. There's one up on Equiplots, a second one is coming, and more will be coming over the next month. So keep it, and that will all be on the revised, renewed Countdown website. And then the third part is the interactions between the data analysis centers and the countries. And I think we are beginning to see more and more interaction between the centers and the countries to get the expertise involved into certain pieces of analysis. So I think that's really a great development, and I hope we're going to see much more of that in the near future. So without further ado, I'd like to invite Jo Borghi and her team to take us into a very critical topic in the annual reviews and midterm reviews, is the health financing. Over to you, Jo.
Thanks so much, Thies, and good afternoon, evening, morning to all of you. As Thies said, this is going to be a webinar on health financing from the Health Financing Data Analysis Center of the Countdown. And I'm joined today by four co-members of the Data Analysis Center. I'd like to just introduce everyone quickly. So I'm Jo Borghi. I'm a professor in health economics at the London School of Hygiene. And I'm here with Catherine Pitt, who's an associate professor in health economics also at the school. Melisa Martinez-Alvarez, who's assistant professor at the school with the MRC units based in Senegal, in Dakar. And Peter Binyaruka, who's a senior scientist, health economist at the Ifakara Health Institute in Dar es Salaam, Tanzania. And Federica Margini, an independent consultant in health economics, who's been working with us on the Uganda country work. So just to give you a quick overview of the session today. So I'm going to begin by giving you a bit of an introduction to financing and hopefully conveying to you why it matters and why it's important and why you might want to consider it in your annual reviews. I'm going to then talk a bit more about potential research questions. So just to sort of illustrate some of the applications, some of the questions that are relevant to financing. And I'll do that with help from Melisa. And then just to give you some concrete examples from work that's already been done in Uganda. Federica is going to talk you through some of the findings from that analysis. And Peter will talk to you about the plans that we have lined up for Tanzania. And then we're going to close with some kind of practical considerations around data. So introducing you to some of the types of data that you might want to be looking at and analyzing on financing, and then some next steps. And there'll be hopefully some time at the end for questions, but obviously feel free to post any questions you have in the chat box as we go through the talk today. So why does financing matter? Well, health financing is a really core input into the health system. It's one of the core building blocks. You're probably all familiar with the WHO health system building blocks. So financing is one of those. And when we talk about financing, we tend to think about three core functions of financing: resource mobilization, pooling, and purchasing. So I'm just going to say a little bit about each of those. So what do we mean by resource mobilization? We're essentially talking about how much money people contribute to health, how the money is collected, the mechanism through which it's connected, whether it's through tax, whether it's out-of-pocket payments, whether it's contribution to national health insurance. Then there's pooling. So here we're thinking more about how the money is brought together and combined. And you can have a single pool. So for example, here in the UK, we have the National Health System, the NHS, the National Health Service. In the US, where it's predominantly private health insurance system, you have lots of pools of funds within each of the private health insurance schemes. And lastly, purchasing. So here we're talking about how the methods for paying health workers, so whether they're paid on a fee-for-service basis, whether they're salaried, or whether it's a capitation or performance-based financing, these are different purchasing arrangements that can be used to pay providers, and the benefit packages that are paid for. So what is the money being used to pay for? Which services are being funded? And in which healthcare facilities? So each of these elements, each of these functions of financing is important for health. So for example, if we take the resource mobilization, where the money's coming from, we know that countries with higher levels of out-of-pocket payments generally have worse health outcomes. And you can see in this figure here, so it's a recent example from COVID, looking at the association between levels of out-of-pocket payment in regions across the world and rates of COVID mortality. And you can see that irrespective of the income group, there's generally a positive association between levels of out-of-pocket, so how much people are paying at the point of service use, and mortality. And obviously the reason for that is access barriers. So if services are more expensive, people are less likely to seek care and therefore have worse outcomes. And when people do seek care, they're more likely to be impoverished, which in itself can worsen outcomes. Now, if we zoom in to the country level, this is a work that Melisa, myself and others did in Malawi for Countdown some years ago. And essentially all we did here was just map out geographically by district the levels of funding. So how much was being paid out of pocket across districts, how much money was coming from government, and looking at that in relation to mortality, so under 5 and neonatal mortality. And what we found is that districts with higher levels of out-of-pocket payments had significantly higher levels of under 5 and 1 to 14-month mortality rates. So moving on to the second financing function, which is pooling. So the way that and the extent to which the funds are combined within a country. This graph here essentially shows you that countries with higher levels of pooling, so where there is like a single pool, be it a national health tax funded system or a national health insurance scheme, you generally find higher levels of universal health coverage. So higher levels of access to care and more affordable health services for the population. And purchasing, the final financing function that we talked about earlier, also matters. So the way that we pay providers, we know that that can make a difference to the services that are delivered. So for example, fee-for-service, where you pay provider for every fixed amount for each service provided, is generally found to be associated with what we call supplier-induced demand. So providers delivering more services, sometimes not necessarily so beyond the optimal level. And there's a study there, which you can see to the top right, looking at the rates of C-section in Chile being linked to fee-for-service, a reimbursement of providers in a private health insurance system. Payment for performance, where providers are paid a certain level of incentive based on the quality and the quantity of services delivered, can increase both quality and quantity of services, with some provisos depending on the context and the way that the incentives are designed. And also we know that when you change how you pay providers, this can impact on service delivery as well. So when you, for example, remove incentives, that can reduce motivation with negative outcomes for service delivery. So here to the right, we've just got a little diagram there which kind of maps out, I suppose, the linkages between the financing functions we just talked about. So the revenue collection mechanisms that are then pooled or not pooled to various degrees, how that money is then used to purchase services, and then service delivery to the far right. And it's worth pointing out that when we talk about revenue collection, we tend to think about three traditional sources of financing at the country level. And Melisa will say a bit more about this shortly. The external financing, donor financing on the one hand, which are particularly predominant in lower income settings, and then domestic financing, which is a combination of household contributions through out-of-pocket payments, through insurance contributions and tax, and government financing, which ultimately also comes from households. So I'm going to now, having talked a bit about financing, move on to some potential research questions. So these are some, I'm drawing quite heavily on this slide from past research that was done with the Countdown initiative. So a big element of the work that's been done by Countdown is tracking resources. So that's tracking the levels of funding for health and for reproductive, maternal, newborn, child health, and potentially looking at how much money is going to maternal versus child versus reproductive. So the sub-domains within that, looking at funding levels nationally, globally, sub-nationally, comparing levels of financing to outputs or outcomes, like we saw with Malawi maps that I showed you before. So how does financing compare to outcomes and equity? But not just looking at the levels of funding, but also the quality of that funding. Melisa led some previous analysis on aid effectiveness and looking at the harmonization and alignment of aid for reproductive, maternal and child health. Equity analysis is another important area. You'll see some illustrations from Uganda of work done on equity, but another dimension which is interesting to look at is how equitable the overall financing system is. So looking at the burden of financing contributions across your population according to the different sources of funding. So for example, looking at tax, out-of-pocket payments, insurance, who's contributing to each, and how that's distributed across the poor to the least poor within the population. And then overall that allows you to say how progressive or how pro-poor or pro-rich your financing system is as a whole. And another example of research is just looking at the impact of financing reforms on health outcomes, on access to care, affordability. So lots of countries have been removing user fees, for example, for maternal health services, and you can maybe look at what effect that's had on service uptake and quality of care. So that's all I'm going to say for now. I'm going to hand over next to Melisa, who's going to talk a bit more about other research questions you might consider. Melisa, over to you.
It helps if I unmute. Thanks so much, Jo. So just a little bit of a recap and potentially a different way of framing the health financing system, but still very consistent with Jo's mention of the three financing functions. So here at the top, we have the sources of financing, which in low and middle income countries are citizens themselves, who either pay directly to healthcare providers as out of pocket, or they make contributions to health insurance, or they pay the government through taxes. We also have corporations who sometimes contribute to health insurance scheme for their employees, and they also pay corporation tax to the government. And of course, we have external financing, so donors providing aid either to the government or to non-government organizations. And sometimes they also give money directly to citizens through cash transfers. And then once the channels, the middle level, the pools of funds, we have health insurance. So that pot can be used to pay healthcare providers for services, but there is also an element of reimbursement to citizens. Governments can also directly pay healthcare providers or make contributions to social health insurance. And then, of course, non-government organizations can either provide the healthcare themselves or pay healthcare providers for those services. So when you're thinking about doing annual reviews, you can, or research on financing, you can actually research any of these components separately or as a whole system. Next slide, please. Thanks. And yeah, I'll go very quickly through this because Joe has already mentioned that we can look at issues of efficiency, equity, policy implementation, and also that we can study financing from the global, national, and subnational perspectives. So if I can, yeah, thanks. So some sample research questions. We can look at health overall. So for example, we can look at how much a country is spending on health, and this is very typically done in annual reviews. You can look at expenditure per capita or as a proportion of GDP or as a proportion of general government expenditure. And for example, African countries have signed to the Abuja Declaration of spending 15% of their funds of their government expenditure on health. And you can also look at trends over time, or you can take a sort of regional or global perspective and compare different countries either by region, by income group, etc. And you can use the same indicators. Next slide, please. So looking at some of these boxes in my initial framework in a bit more depth, and Joe has already gone through some of these, but if we want to, for example, do research on financing sources, if we look at citizens, we can ask research questions on, for example, how regressive or progressive are citizens' tax and health insurance contributions. So are the rich paying more or are the poor paying more? We can look at the proportion of total health expenditure, which is out of pocket, which is the least equitable of all funding sources. And we can also look at catastrophic out-of-pocket expenditures, so people who are impoverished by incurring health expenditures. And Catherine and myself will go through some of the data sources available for these analyses, but I'll just mention them here briefly. And there are secondary data available to do this kind of research, mostly coming from household surveys for citizens, such as the mix, the demographic health system, household budget surveys, and income and expenditure surveys. And sometimes countries have these data disaggregated by RMNCH or for RMNCH. In terms of external financing, Joe has already talked about the different sort of examples. And often we talk about distribution and quality. And the data sources here are the Creditor Reporting System, which Catherine will talk to you about in more detail, but there is also the database of the Institute for Health Metrics and Evaluation, the AData database, the WHO Global Health Expenditure database, which I will talk to you about. And then there is the Muskoka 2, which Catherine will present on, and which does allow for analysis on RMNCH. Next, please. And then if we want to look at channels, we can look at government expenditure. And often here, researchers want to look at how the government spends its health budget. So you can look at how much goes, for example, to salaries versus infrastructure, or different levels of care, primary versus tertiary. You can analyze the distribution of government according to some measure of need, such as geographic, health, or priority groups, or income levels. And there are potential political economy questions around drivers of government expenditure, decision-making, the impact of aid or shocks on expenditure. And the secondary data here available come mostly from the WHO Global Health Expenditure database, but also countries typically have budget books, national health accounts, public expenditure reviews, and government policy documents. And in some countries, data are available specific to RMNCH. I won't talk much about health insurance, but just to let you know that there are a lot of potential research questions about fragmentation, level of pooling, and the benefit package. And here, secondary data are available from health insurance claims reports or documents, policy documents, and again from the WHO Global Health Expenditure Database. And in some cases, data are disaggregated by RMNCH. Next, please. That's it. I'll come back in a bit.
Good afternoon, everyone. I will now guide you through a practical application of this approach and talk about what we did in Uganda. So first of all, we started conducting an analysis of the, next slide. Thank you, Joe. Of the total expenditure on reproductive health by source of financing using the NHA data. First of all, what we did is we really tried to translate these figures in real term to understand the trend over time in these specific areas of health. And what we observed is that over time, the total expenditure on reproductive health had been roughly stagnating, actually in real terms slightly decreased. And in particular, what was interesting is that according to the NHA assessment, the private sector, so private individuals, were those contributing the most to expenditure on reproductive health. And this, as was mentioned before, will, and as you may all know, would cause major problems in terms of equity, quality of care, and also implications in terms of health-seeking behavior. Next slide, please. Secondly, we tried and conduct a more in-depth analysis of external financing using the data through the OECD Creditor Reporting System database using the Muskoka-2 algorithm. Here again, we conducted an analysis in real terms using 2080 US dollars. And what we have seen, firstly, is to try to really unpack this financing to this area. And what became evident was that reproductive health was the component where donors were providing most resources, and instead other areas of sub areas tended to be, if you want, put in a second position. So, for example, as you can see over the time frame considered, which is almost a decade, maternal and newborn health seem to have been prioritized. Quite a lot of resources were also channeled through these others area, which tend to include a number of very specific interventions, which also include, for example, but not exclusively, nutritional supplements. Next slide, please. Secondly, we really tried to understand how are these external resources channeled. And over time, there has been quite a significant difference in the channel which was preferred by donors. So first of all, there's a good news for us all, which shows that over time, it has, in absolute terms, the allocation to these areas has increased. However, after 2016, the resources have roughly stagnated. And when we also conducted the analysis in per capita terms, what we observed is that this absolute increase in the allocation was not actually, did not really meet the population growth rate of over 3.3% per year. And in particular, what was quite interesting is like whether until 2014, very few resources were channeled through the government system. After 2015, an ever-increasing amount of resources would actually channeled through the government, which therefore reduces the fragmentation of the pool of resources. And also quite interestingly, as of 2016, there's a new aid delivery modality which entered, which is the private sector, which within the Ugandan context is taking an ever greater role in health service delivery for this area, but not exclusively, so more broadly. And at the same time, we have observed that in absolute term, the amount of resources channeled through donors' international organization has instead increased. And here, and this finding also poses questions in terms of the amount of resources that actually reached facilities for health services delivery, because as you all know, donors and other international organizations tend to have a higher cost in terms of really for cover services and their offices in a central level. Next slide, please. We also tried and assessed what has been the volatility in external aid over this decade. And what we observed is that over the period that we considered, the United States, where the donors who provided by far and large the greatest amount of resources. However, their contribution has significantly decreased in 2015. We tried and unpack and try really and understand what was the driving cause of this and whether any other donors stepped up. And what we have observed is that in the same year, the Global Fund has significantly increased its contribution to reproductive and maternal health in Uganda. However, the increase in the Global Fund contribution was not equally as large as a reduction in the contribution from, of the United States. So in absolute terms, what we observed is that there was an overall reduction in the resources channeled to the sector. It is worth noting that the high dependence for these areas of health on financing through the United States poses question and threatens the sustainability of health service provision in the country. Next slide, please. Last but not least, we also tried and understand and unpack what have been the trend in the government allocation to this specific area. However, government data did not allow us to conduct a specific analysis of resources channeled to reproductive, maternal, neonatal, and child health. And therefore, we have conducted an overall analysis of health expenditure using budget data. So, what is of particular interest for us is really and try and compare the expenditure which took place between regional and national referral hospital, other central agencies, which includes, for example, the Uganda AIDS Commission and the Central Medical Store, and also, of course, the Ministry of Health, and also local governments. And what is interesting to observe is that over time there has been an overall increase in the allocation of domestic resources. But the composition of this allocation of this expenditure has remained roughly constant. So as you can observe over time, among what are considered other central agencies, non-wage recurrent, so the funds that are used to cover operational expenses, tended to cover the vast majority, over 90% of the expenditure, whether almost the opposite trend was observed in local governments, whereas instead, most of the allocation here, more over 85%, consisted of wages. So the allocation that were made to cover for staff salaries. Next slide, please, and over to Peter.
Federica, I just saw there's a question from Tees.
Yeah.
I wondered if you wanted to answer. It's directly relevant to this slide. He's asking, he says, obviously there's quite detailed data available on financing in Uganda. He's wondering if that means that they're frequently conducted national health accounts with sub-accounts. Could you comment on how?
Yeah, I could comment on that. So
yeah.
By the time we conducted the analysis, so it was August 2020, there wasn't any really recent data from the national health accounts, because the most recent data was from financial year 2015-2016. And so these actually led us to pose some methodological questions on how to best approach it. So the level of detail of these analyses, I think it really comes from the analysis that Catherine and colleagues did using the OECD Creditor Reporting System data. However, if we had to conduct the analysis now, we would have available the most recent NHA data, which covers up to financial year 2018-2019. And in this case, yes, we would be able to conduct some analysis using the sub-account for reproductive, maternal, neonatal, and child health. And if any of you is interest to see this data and how the trend evolved in the last 3 years, you can access the report on the Ministry of Health website, and I will put the link in the chat.
Brilliant, thanks. So, Peter, over to you.
Okay, thank you. So I will continue from where Federica left. So here I'll present the equity analysis which we conducted for Uganda in such a way that we try to understand the budget allocation across districts, 114 districts in Uganda, with different measures of economic status, of which we use the GDP per capita. And here you see these two graphs here for 2 time periods, so the financial year 2016 and 2017, and the 2020-2021. And here we assessed the cumulative proportion of expenditure per capita on the vertical axis, and the horizontal axis is the cumulative proportion of districts ranked by the GDP per capita in terms of the economic status. And here is the Lorenz curve as well as the concentration curve. So the curve which is below the line of equality is the Lorenz curve, of which reflects the income inequalities in favor of the richest districts. But the other curves is for concentration curves for measuring how the allocation of budgets have been across districts of different economic status. And what we see here is that it's fairly equally in 2016, 2017, because most of these curves are almost lying within the line of equality. However, the concentration index is negative, suggesting some sort of pro-rich in terms of budget allocation. However, it wasn't significant in this year. But in 2020, 2021, you see the concentration curves are slightly above the line of equality, which suggests that the budget allocation somehow has been in favor of the poorest in terms of the poorest districts. And the concentration index is negative with a borderline significance in that case. So somehow it's not that clear, but somehow signifying that there is some sort of indication of being pro-poor in terms of allocating budget over time in Uganda. Next. Yeah, so I will talk you through the Tanzanian case study as an example. And here I will focus much on the planned analysis, which we are planning to do, to conduct here in Tanzania. And basically it will be at the national level as well as at the sub-nation level. So we intend to undertake 4 types of analysis. So the first analysis is just to analyze the annual health financing by source. And this will be across different districts in Tanzania and over time from 2015 to 2020. And the different sources here, we mean the government funding, the donor funding, as well as the private expenditure out of pocket for this case, and also the contribution of to insurance or insurance coverage over time. So we can see how the funding has been trending over time, and also the proportion of funding between different sources of funding over time. The second piece of analysis, we intend to analyze the health financing equity at the district level. And here we see how the financing has been done, or the allocation or spending has been with respect to district level of economic and health need. So in this case here, the economic need, we can just use the GDP per capita, as well as we can use some proxy measures in terms of socioeconomic status of the population. And for the health need, we intend to use some measures of health outcome, like mortality, for example, the under 5 or infant mortality rate. And then we see whether the distribution of funding has been disproportionately with these measures of need, both economic and health need. And then we can capture the equity trend over time as well. The third analysis is to try now to see how they relate now in terms of health system input, in particular the financing input, and also other inputs such as human resource for health, as well as availability of commodities. We can see how these inputs do relate with different measures of health system output or outcome. And here we intend to use the coverage estimates for outcome, but also health outcomes measures such as mortality rates. And then we can perform sort of correlation analysis to see how they relate, whether the funding do relate with the health outcome in which way, positively or negatively. The last analysis which we intend to do is now at the very, very lower level, at the facility level, analysis to see the level of funding across facilities. And here we just focus on 2 types of program which has been implemented in Tanzania. So the result-based financing, which has been implemented in 9 regions in Tanzania. And here we just use 1 region of which we have the data to see how the incentive are being paid to these facilities over time, but also the health basket fund through the direct test facility financing program. And this is the donor funding being earmarked to the health sector, which has been implemented country-wise, of which this fund has been paid to facilitate bank account directly from the Ministry of Finance. So we can see the trend of this funding over time, but also we can compare that with different facility characteristics, because we do have some other sources of data at the facility level, of which we can identify whether the funding has been related to what extent to the different measures of facility characteristics. Next. Next slide, please. Yeah, so here I'll just give you a snapshot of what we are trying to do at the facility level. And so the first example here is from the previous analysis which we did for the Pay for Performance program, which was the pilot here in Tanzania, of which we try to understand the inequality in payment through this program by facility socioeconomic status, of which we proxy the economic status of facility by using the catchment population wealth status. And then we grouped facilities between poor and non-poor, and to see how the trend in payment, which reflects performance over time. And we found that performance has been increasing overall. And in terms of equity, we see that there is that gap in terms of performance payout, meaning that the non-poor actually paid relatively higher as compared to the poorest facilities. But that gap in terms of payment has been closing or declining over time. As you can see in this graph, that trend has been narrowing over time. So there is such a reflection of that the program actually is trying to help in terms of reducing the performance inequality between those facilities which started as poorer compared to those which are somewhat non-poor. Next.
Sorry, Peter, I just saw there's a message question posted by Tis. So he's asking about resource allocation formula. And I mean, Tis, I could just start by saying that countries normally have a resource allocation formula that determines how they allocate funding within the health sector geographically across districts. And they would definitely include usually the types of indicators you mentioned, like population, burden of disease, sometimes historical budgets. Peter, I don't know if you want to comment on the Tanzania case.
Yeah, of course. Those, of course, also in Tanzania, we do use the formula in terms of allocating funding, of which population is taken into account, but also some other measure of disease burden, and also some dimensions of equity in terms of distance from facility to district headquarters, for example, to capture that equity dimension.
Great, thank you. So I'm trying to move on to the next slide. My key has stuck. Strange. Why am I not able to? Oh, there, it's worked. Sorry.
No problem. So this is now the analysis, the preliminary analysis in terms of result-based financing payment by facility socioeconomic status. As I said, this is the recent program, which is the national program across nine regions in Tanzania. But these results here are coming from just one region, of which we try to compare now how the payment has been trending over time across quarterly basis. However, we still miss some data on some of the quarters. But the key message here is that there is that inequality trend, meaning that those facilities which are serving the non-poor actually received high amount in terms of payment as compared to those facilities which are serving the poorest population. But that gap started narrow, was smaller, but increased. But also at the end, in recent years, we see that that gap is being some sort of indication that the gap is becoming narrow over time. So we look over time in terms of the recent data which we get to see whether that trend will continue in terms of reducing the performance and the payment gap.
Hi. So now I was just going to take you through the external financing data. so that you can get a sense of how you might be able to engage in some of these analyses. So I was going to talk through the Creditor Reporting System, which has already been mentioned, and then the Muskoka 2 global data set, and then country data sets. Next slide. Next slide. Thanks. So the Organization for Economic Cooperation and Development maintains the Creditor Reporting System, the CRS, which is the main source of data for external financing, which I'm going to refer to as aid. The CRS contains data reported by 49 bilateral donors, that's countries like the United Kingdom and the United States, 42 multilateral donors, so UN agencies, but also the World Bank, Global Fund, Gavi, and 36 private donors, including the Gates Foundation. There's relatively complete data on disbursements for the years 2002 to 2019, but it's actually far more complete in more recent years, especially in the last 10 years or so, since 2009 when the Gates Foundation started reporting, but there's more and more data from more and more donors that have started reporting in the most recent years. This data set is huge. There are 200,000 to 300,000 data points every year. And the database covers all sectors. So not just health and water and sanitation and humanitarian aid that we're most interested in, but also education and the energy sector and all sorts. So the CRS categorizes aid for health, water and sanitation and humanitarian sectors according to various subsectoral areas. But a key problem for us is that they don't actually categorize these in ways that permit straightforward estimates of aid for RMNCH. Next slide. So I just wanted to talk you through briefly, give you a little idea of what this CRS data set looks like. It can be accessed online on the website that's visible here, and it functions basically like a pivot table in Excel, if you're familiar with them. So this is summary data. And if you see all these numbers in the table, they're each underlined. If you were to click on one of them, you would see, next slide, the data underlying it. So this is the microdata, which I've shown here just to give you a sense of the huge amount of data that's underneath these summary statistics. And you'll see the slider at the bottom because there are a huge number of columns of data, many, many different variables. Next slide. And so in the main data set, you can manipulate it in various ways, filter it just like you can with a pivot table. Next slide. And you can also download the data, next slide, here. And each, because the data is so huge, you have to download each year of data separately. That's 200, 300,000 records per year to download and analyze. So next slide, please. So the Muskoka 2 that we've been talking about is an algorithm which we apply to the CRS data set. And it generates estimates of the monetary value of aid for maternal and newborn health, for child health, defined as children aged 1 to 59 months, and the reproductive health of non-pregnant women. So it includes a directed towards reproductive health and family planning, for which there are categories in the CRS, but it also includes relevant shares of aid directed towards HIV, malaria, TB, basic healthcare, health systems, water and sanitation, humanitarian aid, and general budget support. The idea here being that it recognizes the value of the wider health system in promoting RMNCH. And this Muskoka 2 these Muskoka 2 estimates are accessible in an Excel workbook. Now this whole algorithm and this approach and findings were published last year in Lancet Global Health in a paper by Antonia Dingle and colleagues, which is on the right here, which I would really encourage you to have a look at to understand the Muskoka 2 method in greater detail. Next slide, please. So the global data set includes key data for all the recipient countries, so essentially covering millions of records for the 2002 to 2019 period, but these records are summarized into an Excel database of about 230,000 records. So it's still huge, but actually manageable in Excel. And it produces a range of indicators. It produces estimates of total aid for reproductive health, for maternal and newborn health, and for child health, as well as adding these together to produce estimates of aid for reproductive, maternal, newborn, and child health. It also produces estimates of aid per relevant population. That's reproductive health per woman of reproductive age, aid for maternal and newborn health per birth, and aid for child health per child under 5. So all of these values are shown based on actual disbursements, so not just commitments, and they're presented in constant US dollars. And within the database, in the Muskoka-2 database, estimates can be disaggregated by year, by donor, by the recipient country or region, by the subsectoral purpose that they were directed towards, and also by flow type. So we can look at whether they were official development assistance grants or loans, or private development finance, meaning that they were from a private donor. Next slide, please. So just giving you a little flavor of the results that were published last year, and also highlighting that even in the global data set, we produce estimates for individual recipient countries. So here are the 16 countries that we picked out in the Dingle et al. Paper on the left here, and looked at the trends in aid over time, disaggregated by reproductive health, maternal and newborn health, and child health, as well as counting the blue on the top on those left-hand graphs is relevant shares of aid that was directed towards regions and unspecified recipients. Next slide, please. So I just want to walk you through very quickly to give you a little flavor of what the Muskoka-2 Excel database looks like. It is still a really large Excel workbook. On the Start Here tab, we try to give you a bit of an overview of how it's set up. And it works from outputs and digging deeper and deeper. So next slide, please. So in the first dark blue tabs, we have figures. Many of these are the figures that have been shown in recent paper. Next slide, please. And each of those figures link to data in a yellow tab, which shows the analysis behind it. So in this tab, you can see on the left a pivot table, which is summarizing the more detailed data, and then some simple analyses on the right that are used to link up to the figure itself. Next slide, please. And then this is the detailed data that the pivot tables are linking to. So you can see the key columns across the top showing in green, showing the key variables within the data set that you can use to disaggregate the estimates in various ways. Next slide, please. So the Muskoka-2 country data sets, we set one up for Uganda for the annual review last year. And this is just a slight variation on the global data set, which allows more in-depth exploration. So in the Uganda data set, it includes all the records from the CRS for a single recipient for Uganda, which was about 25,000 records for the period 2009 through 2018. And it, in addition to the basic ones included in the global data set, it also includes additional variables. So the project titles, the short descriptions and the long descriptions as reported to the CRS, as well as the channel of delivery. So whether the money was channeled through the recipient country government, a local NGO, an international NGO, a UN agency, and the modality of the project. So looking at whether it was project specific funding or whether it was going through basket funds or sectoral budget support. So it's a way of allowing a much more in-depth analysis, as Federica was able to present. But it's important to keep in mind that these Muskoka-2 estimates are designed to produce reasonably accurate estimates for individual countries in years, but not down to the level of an individual project. Next slide, please. So just showing very quickly then, the Uganda country data set looks basically the same as the global data set, except it's labeled as being for Uganda. And in the figures, you can see that there are some additional figures on the channel and the modality and the details of the basket funding that wouldn't be possible within the global data set. Next slide, please. And so again, in this detailed data, here on this side of the sheet, it looks exactly the same. Next slide, please. But if you were to go to the right on these columns, of data, what you'll see is that there are a bunch of additional variables beyond that aren't required for the Muskoka 2 estimates, but allow for some interesting analyses looking right down into the detail of what projects were funded in the channel and aid modality, which are interesting analyses to do when you're able to dig down into the detail of a specific country. Next slide, please. So to finish up then, where you can find these data sets. The Muskoka 2 2002 to 2017 data set, which was used, which reflects all the data that was in the Dingle et al. Paper, is already available at LSHTM Data Compass. And very soon we will have additional data sets available in the same publicly accessible location. And so I would recommend that you go to LSHTM Data Compass and just type in Muskoka 2, and that will show the other data sets when they are available. We'll be making the Uganda data set and updated 2002 to 2019. So 2 more years of data sets available shortly. And please don't hesitate to contact me if you are interested in conducting more analyses, and very happy to be contacted in English or French. Thank you. So yeah, that was my quick run through of the CRS and the Muskoka global and country data sets. And I'll turn over now to Melisa, who will go through the domestic.
Thanks so much. I just see there's a question from Tis. I don't know if I can hand this to you now quickly. So Tis is saying, you know, it's a really great resource for country annual reviews, but he wants to know how hard it is to extract a country report with the basic graphs on trends and different RMNCH components.
Quite straightforward, and they've already been prepped for many of the countries and are in that global data set.
Great, thanks, Kathy.
Thanks. So I am conscious of time. I'm going to very quickly whiz you through another important data source, which is publicly available, which is the WHO Global Health Expenditure Database. So you can find this very easily on Google. And just to show you, this is the sort of interface to access the data. And here I just wanted to point out that you can select different indicators. And I will talk you through some of the key ones that can answer some of the research questions I mentioned at the beginning. There are data for 192 countries from the year 2000, and you can select different unit of expenditures. Mostly we use US dollars or constant US dollars, or a proportion of something else. Next slide, please. Joe, I can't see the next slide.
Oh, I just put it up.
So yeah, I can see it now. Sorry, it's probably my connection. Just to show you that in the indicators here, you have all the measures related to health expenditure, so current health expenditure. So you can look at some of the indicators I discussed, proportion of GDP per capita, proportion of government expenditure, etc. Next slide. Yeah. And then if you click again, I think it will show. So again, in financing sources, you can have domestic expenditure as a proportion of total expenditure. You can look at expenditure by source. So you look at aid as a proportion of total expenditure, out of pocket, etc. Next slide. Yeah, next. I don't know if it's just because I'm very conscious of time, feel free to take over. I can't, yeah, now I can see it, okay. And just, I think this is the final one on indicators, that you do also have data on reproductive, well, data on indicators related to RMNCH. So there is maternal health, family planning, nutritional deficiencies, which mostly can be classified as child health, and immunization programs, And I think the next one is my final slide, which I think talks about, oh, no, one more. So this is what the data looks like when you select your indicators, your countries and your years. And just to say that you can download it in Excel or as a PDF. And then final slide, it's about the completeness of the RMNCH relevant data. And I'm going to try to do it from memory because I can't see it, but I think there are data for like, oh, here we go, about 50 countries from 2013 to 2018. And again, if you have any questions or would like to discuss more, I'm very happy to do so. Thanks.
Brilliant. Thanks so much, Melissa. So we're just going to close here with just comment quickly on next steps in terms of webinars. So obviously this was a, quite a high level overview covering a lot of different aspects, but hopefully gave you a bit of an introduction to financing, why you might want to include it in your annual reviews, some of the types of analysis that you could do. But if you want to sort of to go deeper and learn more, we're planning future webinars that will go into more depth on the different data sources. So the Muskoka 2 that Catherine introduced you to, how you might do the global analysis and the global data, and then another session which would look at the country level analysis, a session on domestic financing and the different sources of data available to look at financing at country level, and a session on equity and financing. So thanks very much. I think that's our final slide. So I don't know if there are any further questions that you'd like us to discuss today.
I think we're on the hour. I think this was a great overview. Thanks very much, everyone. And I think it's clear that we can have good and improved sections in the annual review reports on MNCH, international spending trends using Muskoka 2, on I think the input-output analysis at the district level. Countries are really looking into that. And that, of course, is not something you do all the time easily, but I think we're going to make great progress in that. And then things around results-based funding, as we heard also from Peter, which is a big question in the context of GFF that I think we can look into. So this was great, and we're looking forward to more. So thank you very much. And you'll hear from us more on the data and analysis centers. And it's great you already outlined a plan for that, Joe. Thanks, everyone, and have a great day.
Thanks. Bye-bye.
Bye.
Thank you, everyone.